long-term consequences of meningitis are far more sinister than sepsis without meningitis. LP lama puncture being an invasive procedure on a highly vulnerable organ, it is more difficult to investigate meningitis than it is to investigate just sepsis without meningitis. And most ethics committees are reluctant to permit repeat lumbar punctures uh, just for the sake of research, making research into this area difficult. So there are some questions which are very difficult to answer because you cannot do repeat lumbar punctures very easily. And our collective ignorance about neonatal meningitis is actually appalling. We still, have some idea, some surety about neonatal sepsis, but when it comes to neonatal meningitis, we are truly ignorant about many things. So the overview of my talk is going to be as follows. Don't be discouraged with the large number of questions listed here. I hope we'll be able to cover a large part of it. And even if we can't, maybe I'll leave out the last 2 or 3 questions, and I'll be more interested in having an interaction with the audience at that time. So the questions are, which neonates need a lumbar puncture to rule out meningitis? Is meningitis associated with neurodevelopmental impairment, and can it be predicted? Are there any neonates at such low risk of meningitis that we can avoid a lumbar puncture? How do we interpret cerebrospinal fluid findings? Does delayed analysis alter CSF findings? Are there any point of care tests available for, say, CSF glucose in cells? Traumatic taps are pretty common in the neonatal period. So how do we interpret traumatic taps? Can we do anything to reduce the rate of traumatic LPs and increase the rate of culture positive CSF? So this is a problem that all of us face. Is there any role for other inflammatory markers like CSF procal, any role for CSF DNA sequencing, PCR, and other molecular methods? How long does it take for abnormal CSF findings to normalize after you start giving antibiotics? How long should one treat with antibiotics? And finally, what is ventriculitis and why does it not occur in every case of meningitis? And how do we treat ventriculitis? Okay, so how frequent is meningitis in early onset sepsis? So this is a table which shows the studies on the left-hand column, the kind of patients included in those studies, and the results of CSF culture. That means proven meningitis. So if you eyeball the kind of patients who were included in these studies, the first 2 studies were on patients who just had RDS with antibiotics started to, within quotes, cover pneumonia. You can see that the incidence of meningitis is practically 0% to very close to 0%. But if the blood amongst those whose blood culture was positive, the CSF positivity rate increased to 8%. If you look at all the studies shaded in green, these are those who are asymptomatic but at risk of early onset sepsis or had just some suspected early onset sepsis without major risk factors. Again, the incidence of meningitis is very low. The last study, clearly symptomatic early onset sepsis or culture positive early onset sepsis, the incidence again is high, 9%. So what do we conclude from all these studies? A, that there is a very low incidence of meningitis in neonates who are simply at risk of early onset sepsis, but who are asymptomatic. So if you are risk but asymptomatic, very low incidence of meningitis. There is a higher incidence amongst symptomatic early onset sepsis or blood culture positive early onset sepsis. How frequent is meningitis in late onset sepsis? So these are data from some well-designed studies, all were prospective, non-case controlled design studies, including one study of ours, the one at the bottom, reasonable sample sizes. And if you just eyeball these figures, the ballpark figure seems to be somewhere between about 5 to 10% of all late onset sepsis will have proven, culture proven or PCR proven meningitis. So what do we conclude? That there is a much higher incidence of meningitis in late onset sepsis compared to early onset sepsis. And there is a higher incidence with positive blood cultures than negative blood cultures, which we have seen in the previous slide as well. And since it is not possible to predict in advance who will turn out to be blood culture positive, therefore, it is safer to do a lumbar puncture in all cases of symptomatic early onset or late onset sepsis. Just summing it all up. So is LP really necessary as a part of the sepsis workup? Let's look at these scenarios. If there are only risk factors, but the neonate is asymptomatic, hardly 0 to 1% risk. No risk factors of early onset sepsis. Baby he just has some RDS, antibiotics started to cover for possible pneumonia, again, very low risk. Symptomatic early onset sepsis, around 5%. Suspected late onset sepsis, around 5 to 10%. And if it's culture positive, late onset sepsis, around 10 to 15%. So LP must be performed in all cases of symptomatic early onset sepsis with risk factors of EOS and in all cases of symptomatic late onset sepsis. Is meningitis associated with poorer neurodevelopmental outcomes? So, what is the incidence of death and neurodevelopmental impairment in neonatal meningitis? So, in low and middle income countries, systematic reviews have shown that the mortality from neonatal meningitis ranges from somewhere between 40 to 58%, but long term data is scarce from low income and middle income countries. In high income countries, the mortality rate from neonatal meningitis has been stabilized at about 10% for several years now. But even in high income countries, 50% of survivors of neonatal meningitis have some degree or other of neurodevelopmental impairment. And 15 to 25%, which is a very big number, have moderate to severe NDI. 5-year-old survivors of meningitis have 4 to 16-fold greater incidence of severe disabilities compared to controls without meningitis. So it does have very, very severe, serious long-term consequences. So you cannot afford to miss a diagnosis of meningitis. Preterm infants, as it is, are more prone to neurodevelopmental impairment. With meningitis, they have significantly higher risk of death and disability compared to term infants with meningitis. And it seems that all kinds of organisms cause NDI when they have meningitis. Their risks are approximately similar. And in general, the risk of NDI is not affected by the pathogen which is causing the meningitis. Now, can the NDI among meningitis be predicted? So I'm just presenting two studies here. One was in 2021, published in the Journal of Clinical Neurology, where they had 77 neonates with proven meningitis and excellent follow-up data. 30% had neurodevelopmental impairment, and the split is shown here. Developmental delay, cerebral palsy, autism. What they did was they took a whole lot of predictors to see which clinical predictors, which radiological predictors were able to predict who would go on to develop neurodevelopmental impairment. So these are basically ROC curves in which they either took only clinical predictors, only neuroimaging predictors, and a combination of clinical and neuroimaging variables. And to cut a long story short, what they found was the most important clinical predictors for long-term impairment were the presence of seizures in neonatal meningitis and the need for vasopressors. And among the neuroimaging predictors, the presence of cerebral vascular lesions. In 2018, Mao et al. Had published a systematic review of risk factors predicting prognosis in neonatal meningitis. Amongst the predictors of NDI were again seizures. So seizures is an important predictor of bad outcome, and high CSF protein in this systematic review were the best predictors, followed by coma, need for ventilation, and leukopenia. And after that, followed by very low CSF glucose, thrombocytopenia, prematurity, and altered sensorium. So just remember, seizures is a bad predictor, high CSF protein, bad predictor, coma, need for ventilation, and in this other study, vasopressors. Predictors of mortality, bulging fontanelle was the most important predictor, followed by low birth weight and early onset and so on. So so therefore it means that we cannot afford to miss a diagnosis of meningitis, the outcome being so bad, although it is possible to predict, which subset is most at risk of bad outcomes. Now, all of us, when we are faced with this guideline that you should do an LP in all symptomatic cases of sepsis, sometimes we always have neonates whose sepsis is so mild that you start wondering whether it's really worthwhile doing an LP or not. So this question, are there some neonates at such low risk of meningitis that LP can be safely avoided? To answer this question, we actually did a study in PGI, which was published in the American Journal of Perinatology in 2020, whether there was any low-risk subgroup in which LP can be safely omitted. So what we did was a reasonably good sample size of 300 LPs were prospectively enrolled for suspected late onset sepsis or symptomatic early onset sepsis. And information was recorded prospectively on a wide variety of demographic predictors, 17 clinical signs, wide variety of laboratory tests, sickness severity scores, whether it was localized to one organ or not, the infection. And we found that definite or probable meningitis was associated with 13 variables amongst the many variables that we studied, and those are all listed here. I'm not going to read all of them. What we did was we found 58 subjects who did not have a single variable associated with definite or probable meningitis. And we said that these subjects could be considered to be a very low risk subgroup because they did not have even one variable associated with meningitis. And to our surprise, we found even among them, 29% had CSF parameters that were very close to the threshold for, suspecting meningitis, so they had possible meningitis. So we concluded from this study, we did many permutations and combinations, that there is no subgroup in which you can confidently say that LP can be safely avoided. So if you're suspecting a symptomatic clinical sepsis, unfortunately, with the current understanding, you have to do a lumbar puncture. How do we interpret CSF findings once we get it? Now, this is a very confusing and controversial area. Let's look at the cutoff values of CSF, WBC, glucose, and proteins. So there is a wide variety range of values in literature. But here is a table showing the most, within quotes, popular and accepted cutoffs. So between term and preterm neonates, there are differences. But WBC counts, most studies would consider it to be positive if it's above 20, anyway, somewhere between 20 to 20, above 25. In preterms, above 25 to 30. Glucose, if it's less than 33 to 40 in term, less than 23 to 24 in preterm. And protein, various studies above 120 to 170, and in preterm, slightly higher cutoffs of 150 to 170, sometimes 180. So what we did was, in 2023, we published the first ever meta-analysis of CSF counts and chemistry for the diagnosis of bacterial meningitis in young infants, with this reference standard being CSF culture or gram stain or PCR. And again, to cut a long story short, using the usual process for meta-analysis, we ended up with 16 studies for quantitative analysis. And this shows the risk of bias graph. Now, what was the results of our meta-analysis? So here's WBC, protein, and glucose. Here are the number of participants, and we had fairly big sample sizes of this meta-analysis for WBC, over 31,000 participants. So at the median specificity level, let's look at the pooled sensitivity. We find that WBC and protein had roughly similar pooled sensitivity, but the sensitivity of glucose was much less than that of WBC and protein. Area under the ROC curve for this meta-analysis, again, roughly similar area under the ROC curve, around 0.89, 0.87. Anything above 0.9 is supposed to be reasonably a good test. But for glucose, it was much lower. So the first thing we concluded was that CSF, WBC, and protein are better than glucose in predicting meningitis. We then calculated the probability of meningitis once you have got a CSF report. So this table, I'll just walk you through it. The left-hand column shows various clinical scenarios, which is basically the pre-test probability. Before you've even done the lumbar puncture, what is the chances that the patient could be having meningitis? So 3 scenarios we have thought of. Not a very sick patient, just some mild symptoms, LPs being just to rule out sepsis, where maybe there's only a 2% probability to start with. Your run-of-the-mill patient with sepsis, the usual symptoms, 5%, and a really sick patient with probably some neurological signs and symptoms, so around 10% prior risk of meningitis. We are dealing with the CSF WBC, CSF protein, and CSF glucose. And for each of them, there are 2 scenarios. The CSF result is either abnormal or it is normal. So abnormal is all in orange. The normal is all in green for each of these tests. So let's look at what if the tests are normal, the green horizontal rows. So CSF, WBC, protein, and glucose, if they are normal in a low risk situation, there is almost 0% chance that it could be meningitis. If it is a run-of-the-mill usual type of sepsis patient, again, if it's normal, very low chance of it being meningitis. And hardly 1 to 3% chance of it being meningitis, even if the patient is very sick, but all the parameters are normal. So it is good at excluding meningitis. What if the parameters are abnormal? Now let's focus on the orange lines. So if you're doing it just as a part of routine workup, if it's abnormal, roughly a 15% chance of meningitis. If your usual run-of-the-mill patient, if it's abnormal, as you can see out here, somewhere between 27 to 30% chance of meningitis. If it's a really sick patient, neurological signs and symptoms, even then, it's worth noting that the probability of it being meningitis doesn't cross 50%. You're still somewhere in the 45 to 50% range. So what does this tell us? That normal parameters are good for excluding meningitis. But abnormal parameters, even in a sick neonate, the probability of it being meningitis does not really even cross 50%, which means we are probably still over treating around 50% plus patients who have abnormal CSF, WBC protein and glucose. So the question again then is, okay, then what do the rest have? The ones who do have abnormal CSF, WBC protein and glucose. So possibly it's viral meningitis, possibly other conditions that can cause minor derangements of these parameters, maybe perinatal asphyxia, maybe seizures due to any cause can cause a little bit of derangement of cytochemistry. So they are not great at positively predicting the presence of meningitis. Okay. Having said that, does delay in analysis of the CSF samples affect WBC and glucose? Now, this is a reasonably common problem in most hospitals. You do a lumbar puncture, but it's waiting to go to the lab for some time. In the lab, the technician has other things to do, so analysis gets delayed. So to answer this question, we did this study which we had published in the Archives of Disease in Childhood in 2009, the effect of delay in analysis. What we did was we took CSF samples of neonates with suspected sepsis. We analyzed it within half an hour as soon as we had done it for the CSF WBC protein and glucose. And then from the same sample, we again analyzed it at 2 hours, and from the same sample again at 4 hours. So the blue line is the CSF glucose. The red line is CSF WBC, and the green line is the CSF polymorphonuclear count. And as you can see, there is a decline in glucose with time. There is an even more sharp decline of the CSF WBC count and neutrophil count with time. So much so that the counts in many cases fell to such an extent that the whole diagnosis of meningitis changed. Or in the case of glucose, it fell to such an extent that someone who was not actually meningitis was now being diagnosed as meningitis based on the hypoglycemia. So it is very important to get a CSF analyzed within a short span of time, preferably within half an hour, because of the rapid changes in the CSF parameters with delay in analysis. So I think it's important to invest in a side lab near the NICU, which can do at least the cell count immediately and ensure the sample for chemistry reaches the lab quickly. So if there is such a rapid decline, can we do any point of care tests for CSF glucose to avoid spurious decline with time? So to answer this question, we did this study, which we had published in the Journal of Perinatology 2 years ago in September 2024. We tried to measure CSF glucose using an ABG analyzer. So most arterial blood gas analyzers now have a provision for glucose in the blood. So we tried to use it for CSF or using a glucometer. So that means putting a drop of the CSF on the glucose sticks and then seeing if you measure it on the glucometer, what happens. So here are scatter plots. So we took 97 neonates with suspected sepsis undergoing lumbar puncture. The left-hand side graph shows the lab CSF glucose on the x-axis, which was the gold standard, and the arterial blood gas machine CSF glucose on the vertical axis. So you can see that on the left-hand side plot, the dots are all falling on this 45-degree angle line, and it's very close to this line. So there was a lot of agreement between the ABG CSF glucose and the lab CSF glucose. However, if you look at the plot on the right side, again, reference standard on the x-axis, glucometer CSF glucose on the y-axis, the scatter plot, the dots are actually all away from this dotted line, which is the 45 degrees reference line showing complete agreement between the two. So that means the glucometer CSF glucose did not agree that well with the lab CSF glucose. We also perform what is known as a bland Altman plot to look for agreement. And on the left-hand side is for arterial blood gas. We found that the difference between CSF lab glucose minus the arterial blood gas glucose was not a great deal, especially in the range of values which are important for decision making. The mean difference was only minus 2.47 milligrams per deciliter. But the same was not the case with glucometer glucose. With glucometer glucose, the dispersion of values was much more. And in fact, the average deviation was 15.5 milligrams per deciliter. So we concluded that if you want CSF glucose quickly, you can use your arterial blood gas machine, but not the glucometer glucose instead of while waiting for the lab glucose. Are there ways to do point of care tests for CSF WBC? So we were wondering whether the leukocyte esterase in the multisticks or dipsticks could be used for CSF WBC while we are waiting for the lab report. So again, we did a study which in the meantime has now got published in the Journal of Pediatrics and Child Health, which is an Australian publication. We had taken 344 neonates with suspected sepsis undergoing LP. So the CSF leukocyte and neutrophil count were performed within 30 minutes of performing the lumbar puncture, which served as the gold standard. And CSF leukocytosis was defined a priori as more than 25 cells per microliter. And simultaneously, apart from the routine tests, 10 microliters of CSF were pipetted onto a multisticks, and the leukocyte esterase was read as nil, trace, moderate, or large. And we took positive leukocyte esterase as anything which was moderate or large. What we found was that when we tried to correlate the values, there was a very poor coefficient of correlation. It was, I mean, just a modest coefficient of correlation. The leukocyte count, it is 0.49, although the p-value was significant. But when we try to look at the accuracy to predict leukocytosis, the sensitivity was only 63%. Specificity being 91%, sensitivity of 63% would be too low to be able to use this as a screening test for CSF leukocytosis. So we concluded from this that leukocyte esterase cannot be used because it is poor sensitivity and only a modest correlation with the CSF WBC count. Now, all of us have faced this problem of traumatic lumbar punctures in the neonatal period. And that's because the subarachnoid space is so small and it's difficult to ensure that the needle exactly enters into the subarachnoid space. So there have been very many formulae described in textbooks for how to correct for traumatic LPs. So this was a landmark study conducted by Greenberg et al. In 2008. They defined traumatic LPs as more than 500 RBCs per microliter. So they took more than 6,000 lumbar punctures in neonates, of which 40% were traumatic. And in the literature, this has been the ballpark figure. Approximately 40% of LPs in neonates have either macro or micro trauma. So what they did was, first they took the ones who were non-traumatic, the remaining 60%, where they took the WBC count and calculated sensitivity, specificity, and area under the curve. Then they took all the traumatic lumbar punctures and they used various formulae for correcting for the WBC count. So the first group, traumatic, they did not correct the WBC count at all. They just took the raw WBC count. And in the next 4 rows, they use various formulae. 500 is to 1, 1000 is to 1, observed minus predicted, and so on and so forth. What was interesting in this study, and which no one had expected until then, was that the area under the curve, which gives the overall performance of the test, was almost identical, whether it was traumatic or non-traumatic. And if it was traumatic, whether it was corrected or not corrected by any of the formulas. So what they concluded was that there is practically no difference whether one corrects or does not correct, irrespective of the method of correction. And they actually recommended that there's probably no point in using any of these formulas for trying to correct trauma for traumatic lumbar punctures. The same kind of study was repeated in an even bigger study, more than 20,000 lumbar punctures, of which about 14% were traumatic. And it used roughly the same approach, and they arrived at almost the same result, same story, hardly any difference whether one corrects or does not correct, irrespective of the method of correction. So the conclusion from both of these was there is really no point in correcting for RBCs in traumatic lumbar punctures. Either you say that it is unreliable and I'm not going to rely on it, I'm going to repeat a lumbar puncture after 24 to 48 hours, or if you do rely on it, that the RBC count is not too high, then just simply take the uncorrected WBC count and don't even bother to correct. In fact, the NICE UK guidelines, they do not recommend correcting for RBCs. But is it still possible to reduce the rate of traumatic LPs and improve the rate of CSF culture? We all have this complaint that CSF culture rates are very low, traumatic LPs are common. So is it possible to do anything about it? So right now, as we speak, we are doing a QI project in PGI. This is a DM thesis project to try and reduce the rate of traumatic LPs and improve the rate of CSF culture. So this is an ongoing QI project. We have already done a baseline data collection followed by 2 PDSA cycles with various care bundles implemented. We're using standard operating procedures, which all the residents are being trained in, video training. We're giving sucrose analgesia during the LP. Needle size is strictly based on weight. We are using Bactec culture bottles to send the CSF for culture. And we are ensuring and educating people to always do an LP prior to the first dose of antibiotics. And I'm not going to go into details. So there's a very detailed SOP, which is shown here, in which all residents are trained. Now, the results of this QI project have been very interesting so far. These are interim results. The project is still going on. So traumatic LP rate in the pre-quality improvement period was 43%, which was the average in world literature, corroborates with that. During the QI improvement process, it dropped to just 25% of that. It's down to 12.8%. And in the current PDSA cycle, which is going on, we are anticipating it's going to drop down even further. The CSF culture positivity rate was only 3.3% before we started this QI project, and it has gone up to almost 8% during this QI project, and we are hoping it goes up even further. So it is possible to reduce the rate of traumatic LPs and improve CSF culture rates. Now, one question that often people ask is how much time does it take for an abnormal CSF parameter to normalize after starting antibiotics? And this has many implications. So this is a slide which is going to deal with the time for abnormal CSF parameters to normalize. And this was published by Greenberg et al. In a very big study in 2011. So what they did was, amongst those subjects who initially had abnormal CSF parameters and whose CSF culture was all positive in the beginning, but cleared in a repeat lumbar puncture done for whatever indications, they took all those patients from a very large database in the US and they published these uh, you know time to event curves. Let's look at culture, which is on the top left. They found that amongst those who were culture positive to begin with, the median time for culture to become negative was about 4 days. Amongst those whose protein was positive to begin with, it took a very long time for CSF protein to normalize. As you can see, the number of days is at the bottom. It takes a long time for CSF protein to normalize. With glucose, it seems to normalize a little faster than protein, but still it's in several days to weeks. It doesn't happen in just the course of a few days. WBC count, again, it takes time for WBC counts to come back to complete normalcy. It can take several weeks, in fact, to come back to complete normalcy. So what implication does this have? Number one, we must realize it takes time for parameters to normalize. Protein takes the longest, followed by WBC, followed by glucose. Culture turns negative quickly within about 4 days. Now, that means that in the initial days, first few days of antibiotic therapy, there is hardly any change in WBC, protein, and glucose. What are its clinical implications? It means you can do a lumbar puncture even after a few doses of antibiotics in the first few days. If you have not been able to do it before the first dose, ideally it should be before the first dose, but if you have not been able to do it, try and do it within the next 3 to 4 days, because your protein, WBC, and glucose do not change so much in the first few days. Second implication is, if you have done it after several days, say 10 days, 20 days, don't use the parameters in the repeat LP to judge improvement, because it takes time to improve. Of course, if it is worsening, it's a different matter. But don't expect them to normalize completely just because you've given antibiotics for a few days. Okay. Now, since all these CSF parameters don't seem to be performing that I know at best, if it is abnormal, it predicts about 45 to 50% probability of meningitis. Are there any other inflammatory markers that could be used in diagnosis? So we asked ourselves this question: does CSF procalcitonin have any role in diagnosis? And we published this study in the Journal of Pediatrics and Child Health in 2022, CSF procalcitonin. So we analyzed 209 CSF samples, of which 97 were above a certain threshold of procalcitonin and 112 were negative. And then you had the final diagnosis based on culture and or gram stain or PCR. And what we found was that for definite meningitis, that means culture proven meningitis, CSF procalcitonin has an area under the curve of only 0.66, which is, for a very mediocre test. Just, ignore the p-value, because p-values may be dependent on the sample size, but the actual performance of the test was not great. When we looked at CSF to plasma procalcitonin ratio, the area under the curve was even poorer, just 0.43. We took a cutoff derived from our own ROC curve, and using our own cutoff, even then the sensitivity was hardly 50%, which is simply not good enough for a test. That's like tossing a coin. For definite or probable meningitis, same story. CSF procalcitonin, area under the curve, only 0.64 of the ratio between CSF and plasma procalcitonin, again, very mediocre. So we concluded from this study that the area under the ROC curve of the CSF procalcitonin is too low to be of any discriminatory value. Is there a role of PCR and DNA sequencing in diagnosing neonatal meningitis? So this was a Department of Biotechnology project, which is yet unpublished. So we looked at universal primer PCR, targeting the 16S rRNA gene, followed by DNA sequencing. So this is the 16S rRNA gene, which has many variable regions and conserved regions. Against the conserved regions, various primers are designed. So we had designed these primers, and finally we did this study using PCR and DNA sequencing. So we enrolled 206 subjects, of which 16 were reference standard positive and 120 reference standard negative. This shows the entire workflow of this project, so it was quite a complicated project. We did a lumbar puncture, extracted DNA, did real-time PCR. That shows, the real-time PCR plots. With the products, we did conventional PCR, and then DNA sequencing. The DNA sequencing result comes in the form of what is known as a chromatogram, which it may be a little difficult for clinicians to follow, but basically it gives the entire nucleotide sequence, and that is matched against a database to identify the microbe. So this is overall the entire workflow of this project. And this is just to show, just some representative diagrams of how these organisms are detected in the CSF. Now, what will be of interest to the clinician is the diagnostic performance. So here is your standard, 2x2 table. The columns show the numbers which are reference standard positive, reference standard negative, and the horizontal rows show how many were PCR positive and PCR negative. So firstly, what we found was that the prevalence of meningitis was about 8%, which is like the usual figure reported in literature for late onset sepsis, and symptomatic early onset sepsis. PCR had 100% sensitivity. It did not miss a single case of proven meningitis. So that was good news. The specificity was also very high, 99%, with a confidence interval from 96 to 100%. And as you can imagine, the likelihood ratios, both positive and negative predictive values were very good. So this is a promising test, not, of course, widely available now, but hopefully in the future, it will be more easily available, which may be better than just using, cells and CSF chemistry. So this is something which to look out for the future, real-time PCR and DNA sequencing for diagnosing meningitis. Now, the question then is that, okay, fine, if you've used all these methods to diagnose meningitis, how long should one treat with antibiotics? So this was a part of a meta-analysis which we had done initially for the NNF CPG guidelines in 2024. And finally, this got published in the Lancet as part of a group of non-inferiority meta-analysis just last year. Of 8 citations shortlisted to assess full text, only one could be included in the systematic review. Just one article, and that too from India. This was Dr. Mathur's study published in 2015. But this solitary study comparing 2 different durations of antibiotics for meningitis had a very high risk of bias. And funnily, they compared 10 days of antibiotics versus 14 days, whereas the convention is actually to give 21 days of antibiotics. But neither of the two arms had 21 days. They had very small sample size, only 35 per arm, and they could not find any differences in mortality or relapse. So, as part of the NNF CPG guideline group, we gave a strong recommendation against the use of short courses of intravenous antibiotics until better data was available. So we feel that, you know, that there is nothing in favor of 21 days, but since it has been in practice for such a long time, we cannot shift from it. We cannot give shorter courses unless we have very convincing data showing that shorter courses are just as good as 21 days. Now, one of the dreaded complications of meningitis is ventriculitis, and this often causes confusion. So, what exactly is this thing, ventriculitis? What is the definition of ventriculitis? Now, the trouble is that there is no universally accepted definition of ventriculitis. So theoretically, the gold standard definition of ventriculitis is when the ventricular CSF is culture positive. But you hardly ever get that in clinical practice, because by the time you have done suspected ventriculitis, done a ventricular tap, sent it for culture, already many days of antibiotics have been given, and the cultures are hardly ever positive in ventricular CSF. So one of the sort of pragmatic definitions is when the ventricular tap CSF cell count is more than the corresponding LP cell count, or you have a positive CSF gram stain, or increase in ventricular pressure, either clinically or radiologically. So this is the definition which has been proposed by the Neonatal Meningitis Cooperative Study Group and by Volpe's textbook of neurology. One operational definition used by a large study in 2020 was completely ultrasound based. They said that whenever you have echogenic or thickened ventricular lining, presence of debris or strands within the ventricles, you call it ventriculitis. This is a thing that many of us use. And so a practical definition in clinical practice is usually some combination of failure to improve on antibiotics, plus lumbar puncture being positive, plus neuroimaging being suggestive. A lot of us would treat that as ventriculitis. And it is important to distinguish it from meningitis because ventriculitis is a significantly more hydrocephalus, seizures, and raised CSF protein and lower CSF glucose than meningitis. So how common is ventriculitis? Unfortunately, that's also not an easy question to answer. There is utter confusion in literature because of varying definitions. Historical studies, mostly autopsy studies, reported extremely high rates, 65 to 90%, but I'm sure all of you will agree that it can't be that high. And since it was, these were all patients who had died, autopsies, they represented an extremely sick subgroup of patients with meningitis. So perhaps that's why these rates were high. Contemporary clinical and radiological studies have much lower estimates. One of the largest studies published in the European Journal of Pediatrics suggested that 20% of meningitis are ventriculitis and mostly amongst the gram negatives. And another recent study said about 5% of all cases of meningitis. A lot of us rely on cranial ultrasound, and I've shown just some cranial ultrasound images on the right side showing, strands and some debris and ventricular dilatation and enhancement of the walls. Is the cranial ultrasound foolproof? No, it is not foolproof. Several findings have been described, but there are no definite criteria. Unfortunately, intraventricular bleeds often result in overlapping findings. And ventriculitis is very important, evolves over time, and single ultrasounds which are reported normal may be misleading because subsequent ultrasounds may turn out to be having findings. MRI is superior to ultrasound, and in one of the largest studies, it was found that DWI and FLAIR MRI detect 95% of confirmed cases, and FLAIR is actually superior to even contrast enhanced T1 weighted images. And the usual findings are intraventricular debris, ependymal enhancement, and low periventricular attenuation. So when should you do an MRI? A 2025 review of the European United States Brain Group suggested that at least one MRI scan should be done in the following two situations. Neonates with meningitis and seizures and abnormal neurological examination, or a neonate who has some ultrasound findings which are considered abnormal. So these two groups should undergo at least one MRI scan at some point of time. Now, a question which often puzzles all of us is that why does ventriculitis not occur in every case of meningitis, although the CSF spaces are all connected? It's not that the ventricles are some disconnected space, and the exact reason, surprisingly, is still not known. So, here are some of the hypothesized reasons. Most widely accepted reason is that the direction of CSF bulk flow is from the ventricles outwards into the subarachnoid space, as shown in this diagram. And so bacteria would have to normally travel in the reverse direction from the meninges back into the ventricles to cause ventriculitis. So that therefore it doesn't occur in every case of meningitis. And the second, and probably the more important reason, is that the primary route of bacterial entry into the ventricles for ventriculitis is through the choroid plexus and not retrograde from the subarachnoid space. In fact, the glycogen-rich, highly fenestrated choroid plexus is highly vulnerable to bacterial invasion. And this hypothesis proposes that ventriculitis and meningitis are actually two different phenomena. And so ventriculitis is not simply, within quotes, a complication of meningitis. It seems to us to be a complication because we often end up doing a ventricular tap if the baby is not improving after several days of treating meningitis. And of course, different organisms have different neuroinvasive capacities, which partly, answers one of the questions that Dr. Ravi Shankar had raised in the introduction. Why do all neonates not develop meningitis? Because there is a difference in neuroinvasive capacities of different organisms. Including, like, for example, the E. coli K1 strain has a greater propensity. Treatment of ventriculitis, now you can imagine if for meningitis itself, there are hardly any randomized control trials. For ventriculitis, there is not even a single randomized control trial. So in a systematic review of observational studies, it is found that there is no data regarding total duration. The convention is 4 to 6 weeks, so it's probably just safe to stick to that. But at least 3 days of intraventricular antibiotics was associated with lower mortality compared to only systemic antibiotics. Very poor quality of evidence, but that is all that we have right now. In PGI, what we often end up doing is, if it is a bug which is sensitive only to colistin, like Acinetobacter or something, we give intraventricular colistin 1.25 lakh units alternate day in alternate ventricles for a maximum of 2 weeks, plus intravenous for 4 to 6 weeks. So to sum up this entire talk, which has covered a lot of ground, neonatal meningitis clearly increases the risk of neurodevelopmental impairment. That goes without saying. And seizures, high protein, coma, and need for vasopressors and ventilation are associated with worse risk of NDI. So if you have a patient with any of these things, be on the lookout. This patient needs to be followed up carefully. Lumbar puncture must be done in all cases of symptomatic early onset and late onset sepsis. And there is no low risk subgroup in which we can say it is safe to avoid doing a lumbar puncture. We certainly need better tests than CSF, WBC, protein, and glucose. They are not good enough. These parameters are better for ruling out meningitis than ruling in. And in that, WBC and protein are better than glucose. If any of these parameters are positive, that is at best only a 50% chance of it being bacterial meningitis. The rest could be viral meningitis or other differential diagnosis of meningitis, and which means that we are actually grossly over-treating meningitis. A delay in analysis definitely alters WBC count and CSF glucose, and there is no particular advantage for correcting for the presence of RBCs in the CSF. Quality improvement initiatives can substantially reduce traumatic LPs and increase CSF culture positivity. Point of care test can be done for CSF glucose using the ABG machine, but points of care tests for CSF WBC have very modest performance. Procalcitonin does not help in diagnosis. CSF, PCR, and DNA sequencing have very high sensitivity and specificity and may be something to look out for in the future. Antibiotics rapidly turn culture sterile, but WBC, glucose, and protein may take a long time to normalize. So if you are unable to do an LP before starting antibiotics, at least try to do it within 3 to 4 days. If you are repeating an LP for some reason, don't simply rely on non-resolution of CSF parameters to say that there has been non-response. And just go on continuing the antibiotics. That is not a reasonable approach. Continue a 21-day regime for meningitis till better data is available. There is no standard definition of ventriculitis. Continue 4 to 6 weeks of IV antibiotics and at least 3 days of intraventricular antibiotics till better data becomes available. Thank you very much for listening so patiently. So we are still on the high seas, charting difficult waters, but we hope someday in the future, we will be able to answer many of the unanswered questions. Thank you very much.
Thank you very much. It's been a wonderful talk.
So just a minute. Yes. So thank you so much for your wonderful talk. Now may I ask Dr. Ravishankar sir to have a comment on that?
Yeah, it's been a wonderful. In fact, it's a provoking talk. We keep seeing so many patients with infections, sepsis, meningitis. We just do it, routinely. There are so many things which we don't know why we are doing it. And you have rightly put it up in a very nice, rationalized way as to what we know and what we do not know about it. So one thing which was there in my mind was, have you ever thought about improving the success of lumbar puncture by doing an ultrasound? Has anybody done in
Yeah, so there are
PGI?
studies,
Yes.
not in PGI, but there are a few studies trying to use ultrasound guided lumbar punctures.
Right.
They're very small studies and showing that it has a higher rate than blindly doing a lumbar puncture. Interestingly, there's also a very well done study on doing lumbar puncture in the sitting position in
Sitting.
units compared to the lateral decubitus position. And the sitting position, there's a clear advantage. Of course, the baby has to be otherwise hemodynamically, respiration wise, etc., stable to be able to hold the baby in that sitting position. And although it looks as though it is uncomfortable, it actually opens up the interspinous spaces much better than the lateral decubitus position. And the success rates of lumbar puncture are actually higher in the sitting position. Of course, there is a certain learning curve to it, but there is a very well conducted study with already a randomized control trial on this showing the sitting is better than the lateral decubitus position.
We have done a small study in our this unit. One of my fellow has done this study, and we have not been able to find much of a difference between ultrasound versus the palpation method.
Right.
And when we went into the this one literature also, they were not very clear cut.
Yeah, there are very few small
Yes,
attempts at doing
and
this.
few of them have told that it's not much, advantageous. But still, I think it's a thing which we can, explore.
Yeah.
Asha, like already, should I take up the questions and ask this, Saurabh, or will you?
No, sir. I'll take up the questions.
Okay, fine.
If your talk is over, shall I proceed?
Yes, please.
No, I'm asking Ravishankar sir.
Yes. You can start. I'll try to.
Any words from Dr. Vijayanand and Dr. Tejo?
Sir, I think first we'll take up the questions, sir. We'll give it, or
okay.
then because a lot of questions are there.
Yeah. So, one question or statement from Dr. Jalil Ahmad. CSF biomarkers like lactate, PCT, interleukin 6, and serum amyloid A can have influence on the prognostication of outcome.
No, unfortunately, none of these markers have really consistently been shown to have anything to do with long-term prognosis. Whatever data is there, which has been systematically reviewed, suggests that, as I mentioned earlier, seizures in the presence of meningitis, coma, very high CSF protein, need for ventilation and shock. These, these 5 are red flag signs that there could be problems in future. And of course, if there's a complication like ventriculitis, then definitely the outcome is bad. But there are actually very few there are no biomarkers which have been consistently been shown to have anything to do with long-term outcome.
Yeah, one thing, just Likareddy, just wait
Sir,
for a while.
sir.
There's been an lot of nowadays the
Lactate.
laboratories are offering this multiplex PCR,
Mhm.
especially in the pediatric age group where the viral panels, bacterials. We haven't tried it out in the newborns, but is there anything anybody has tried out in the newborns?
You
Because
mean you mean
when
biofresh,
a
sir?
pediatric patient comes with encephalitis or something like that, and we would want to know what is a bug. So we do send the PCR in them, and it's a multiplex, and it actually covers more than 20 to 25 viruses, bacteria, and all those things. But has it been have we tried it out in the
Yeah, so I think one has
newborn?
to be a little cautious because I did go into the literature about these kind of panels. They have all been standardized for adult samples, where you can afford to send much larger volumes of blood, much larger volumes of CSF. And again, it has been standardized for the bacterial densities that you get to see in adult sepsis. There actually is a paucity of data when you're sending only 500 microliters of blood and probably even less than that of CSF, how good these are at picking up,
Yes.
right? And all of them, they are trying to match a certain DNA sequence with a database and come to the best possible uh,
Identity.
guess as to what that bug could be. So I think all of you have faced this situation when you use some of these panels, you sometimes get most unusual things all getting reported. Sometimes, 3 or 4 things getting reported in from a sample, and it can't possibly be correct. So I think we have to be a little cautious about interpreting some of these panels. They are still not a reference standard as of now. This is still work in progress for at least for neonates.
Yes.
Sir. May I go to the next question, sir?
Yeah, please.
Yes, sir.
CSF culture and PCR, which is better to detect meningitis?
Yeah, so I don't think we can give a definite answer. From our own study, we found that when we used real-time PCR, which is universal primer PCR, that means that is not being targeted against any one organism. It is being targeted against some highly conserved regions in the bacterial 16S gene, which are common to all known bacteria. That means they evolved very, very early in evolution and have remained unchanged. That means every bacteria has certain parts of that 16S RNA gene. If you're targeting those universal segments, then PCR was able to pick up every single case which was culture positive. It didn't miss a single culture positive case. And in fact, it picked up 2 more which were not culture positive. So that's why we had 100% sensitivity and some almost close to 95% specificity, which I had shown in one of the slides. So but there aren't too many studies of this kind. And so it's difficult to say whether those ones which PCR are picking up in excess of culture, whether those are contaminants because PCR is oversensitive. So any stray bit of DNA which is there in your test tube or vacutainer, anything is being picked up by PCR, or are these genuine meningitis? That means, is it false positive or is genuine meningitis? We do not know. So, but I think there is a good case for more studies to be done on PCR and DNA sequencing to see whether it can replace culture as a method for diagnosing meningitis.
Yeah. That question was from Dr. Mahendra Kumar. The next question from Dr. Pooja Sharma. In case of suspected meningitis, for how many days antibiotics should be given?
Yeah. So whether it is suspected or proven, as I told you, we really don't have much evidence. This 21 days of antibiotics is a number which has just come into clinical practice as a matter of convention without much of a basis. So as of today, it remains 21 days of antibiotics. whether it is proven meningitis or whether it is probable meningitis based on cells and cytochemistry. The number is 21 days for want of any better evidence. Yep.
In this swim, I have a clinical experience. Like I think all of us have a clinical experience. When we do an LP again after a week or 2 weeks, we find that the cell count, the proteins, the glucose, everything has improved. So in your this one, whatever you have presented, you have told it takes many days for changes in
To
the cell count
normalize. It takes
to
days, many days to
normalize.
normalize. I
But
did not say it takes days to improve. So some improvement you will start finding. That means it's coming towards
we
normal.
have, I think all of us will agree that when we do it after a week or two, I mean,
Yeah.
I don't know whether this is really, recommended or not, but when we do it after a week or two, we do find that there is, as the clinical improvement has occurred, in the same way, the CSF improvement also is there.
Yes. So let me again clarify myself. So it takes time for it to come back to complete normalcy below the threshold, whatever is the cutoff that we consider abnormal.
So
But
what? Yeah.
changes towards normalization, you will obviously start seeing from before that. Now, the important thing is that, say, supposing you do it on day 21, you've given antibiotics. So firstly, there is no recommendation that in a patient who has improved clinically, you must mandatorily do a second lumbar puncture on day 21, in case somebody is going to ask me that question. It's a very commonly asked question.
Yes.
So I'm trying to preempt it. So firstly, there is no such recommendation. But supposing you do, and you find that the values have not gone below the thresholds which are used for diagnosing meningitis, don't use that as a reason for continuing to give antibiotics. Because to become completely normal, it's going to take some time. So if the baby has clinically improved, you have given 21 days, ultrasound is normal, you're not suspecting ventriculitis, stop at 21 days.
So it means that essentially that there is no point of doing one more lumbar puncture if the patient is clinically improving.
That's right.
And you give it for 21 days of.
That's right.
I
Yeah.
think that should be the message.
Yeah.
But I have seen earlier that doing a lumbar puncture after 3 days is maybe useful to know whether even before the patient clinically improves, to know whether it's actually improving or not. I have read that.
Yeah, there may be sort of individual articles, but I don't think that's a guideline of any organization or society that you should mandatorily do it at 3 days just to see whether the patient is improving. I think it's still, we would go by, as clinicians, we would take the patient as a whole and go clinically rather than repeating a lumbar puncture.
Yes.
Sir, usually they say that fungal meningitis, we should go for repeat LP after 5 days, and if the culture is negative, you need to count the days from that.
Yeah,
Unlike
for
your
fungal,
bacterial meningitis.
for fungal sepsis, there is a reasonably clear guideline, again based on very weak evidence, I must say. But the IDSA guidelines, Infectious Disease Society of America, and other guidelines say that repeat a fungal culture after 3 days or 5 days, and you have to give 14 days more antifungals after the last negative culture. For blood fungus, there is a clear guideline. For CSF, there is no such clear guideline that you must repeat a CSF after 5 days, and then, because how many times can you possibly repeat a CSF? See, for blood, you can still repeat it. Okay, you did it at 3 days, it is still positive. You can do it at 5 days or 6 days. And from the last negative blood culture, you can give it for 14 days. But you can't possibly go on repeating CSF for, and then wait from the day it becomes negative, I'll give it for X number of days. That's a little impractical. So really there is no such guideline as at present for fungal meningitis.
So the next question is from Dr. Lau. Why difference in cell counts in ventriculitis between
I think there's another question before that. The duration of treatment, whether it
it's a
differs for
statement, sir.
gram
It's not a
positive and
question.
gram negative.
Dr. Jalil Ahmed sir has given a statement rather than a question.
Okay.
Duration of treatment differs from gram positive to gram negative. That is Dr. Jalil Ahmad's statements.
Well, maybe it could be a question also, sir.
Yeah.
Let him answer, I think.
I mean,
Yeah.
I think if it is a question, it's a very
Yes,
good
sir,
question, because most of
Go for it,
the
sir.
guidelines from high income countries for GBS meningitis, they recommend 14 days of antibiotics. Again, not based on, that there was some randomized control trial comparing this regime versus another regime, but 14 days of antibiotics is considered uh, okay for GBS meningitis and 21 days for gram-negative meningitis. There is a little bit of a theoretical reason behind this, and that is gram-negative bacteria have greater propensity to be able to invade the choroid plexus compared to GBS. GBS is not that good at invading the choroid plexus because of the properties of the choroid plexus. It is very glycogen rich and so on and so forth. So there is some weak theoretical reason that your chances of complications are a little less with GBS compared to gram-negative meningitis. So overall, the general thing has been, okay, you can get away with 14 days if it is GBS meningitis, which we hardly ever see in India actually. But you need 21 days for gram-negative meningitis. Yeah, we can go on to the next question.
Next question is from Dr. Lau. Why difference in cell counts in ventriculitis between lumbar puncture and ventricular tap?
Yeah, so it is that just simply based on that, in case the bacteria have been able to, the bacterial density in meningitis is so bad, it's such a bad meningitis that the bacteria are actually able to go retrograde into the ventricular cavity and inflame the ventricular cavity. Its cell count is expected to be more than what you expect in the lumbar puncture. So remember, all these definitions of meningitis have all come from, some experts saying it should be this versus that and so on and so forth. As I said, there is no consensus on the definition of ventriculitis, which is a part of the problem. That because therefore estimating what is the incidence of ventriculitis has become a very, very challenging if you don't have a common definition. But one of the things which this neonatal study group recommended was that in case at the same time, in a parallel LP and ventricular tap, you find a higher cell count in the ventricular tap compared to the LP, consider it to be an independent, ventricular infection, that there is ventriculitis. That's all that there is to it.
Sir, next question from Dr. Pooja Sharma. If the reports are not clear, culture sterile. I think how many days we have to give antibiotics? The above question was
That's a very tough question to answer, because sometimes you get just hypoglycorrhea. CSF glucose is low, everything else is normal, protein is normal, counts are normal. CSF culture is, of course, sterile most of the times. Gram stain is negative. How long should you give antibiotics? I really don't know what is the answer to that. CSF glucose, as I said, is anyway amongst the three is less good at predicting meningitis. Supposing you have cell count normal, only protein and glucose abnormal, gram stain in culture is negative, should you be treating for 21 days? Again, there is really no clear-cut answer to this. A pragmatic definition which we had used in our last multicentric study was simply this, that if either cell count is positive or both protein and glucose are abnormal, means for cytochemistry, both have to be abnormal, for cell count, only cell count, or gram stain is positive or culture is positive, you consider it to be meningitis and you give treatment for 21 days. Remember, if your blood culture is positive, the chances of it being meningitis are much higher than if your blood culture is negative. So the same CSF report would be maybe interpreted if it's borderline. If my blood culture is positive, I will be more inclined to consider that to be meningitis and treat it as meningitis. If my blood culture was also negative, and I am sitting at this borderline, just isolated hypoglycemia and all that, I would be more inclined to not treating it as meningitis. Of course, if you have seizures or coma or a bulging fontanelle, the only three, definite neurological signs, again, I would be more inclined to saying that with the borderline picture, this is much more likely to be meningitis, and I will err on the side of giving antibiotics for 21 days. I hope that, in the midst of all this confusion, I hope that makes some sense.
Yeah, to just add to that, I think most of the times we do a lumbar puncture after giving antibiotics after a few days. So the practice of including lumbar puncture at the initial when we draw the blood samples, as you have rightly pointed out, that it has to be done as early as possible. If you do it before the first antibiotic is given, probably your gram stain and culture positivity rates will improve. So that's very important message what you
Yeah.
have given. And the other important message which you also have given is that it has to be processed fast.
Yes.
So if it is not processed, because many, I think all the hospitals face this problem that it is not processed well. It takes a lot of time, 2 hours, 5 hours, 6 hours. So ultimately, your cultures are not going to be positive.
Yeah.
And
There's a linear decline in your cell count.
and many of these, viral infections have come up a lot.
Yes.
These days, with somehow the decline in so-called bacterial infections, we are finding a lot of babies are getting admitted, so-called healthy babies who come, they become dull and they have some kind of, convulsions. And you don't really have any abnormal CSF profile, except for a bit of hypoglycorrhea. I find that, this, viral infections at times they do produce this, hypoglycorrhea, especially if we are dealing with the serious bugs.
Yeah, so especially if you get a high lymphocyte count, you don't have polymorphonuclear cells, and your chemistry is more or less normal, it could very well be a viral meningitis. These are much commoner than what we, realize. And I think that is one place where these panels of PCR and so on would really be helpful for excluding viral meningitis, because we are very poor at diagnosing viral meningitis. In high income countries, enterovirus is one of the commonest causes of neonatal meningitis, which we somehow fail to pick up, and we don't realize that many of these are viral.
We don't look for it. We don't look for
We
it,
don't
sir.
look for it. Yeah,
Yeah.
that's true.
So the next question is from Dr. Rupam. Prognosis in terms of NDA, bacterial versus fungal meningitis, are they same?
I really don't know the answer to that question, I must admit. I've never come across, I never actively, systematically searched for any head-to-head comparisons between bacterial and fungal meningitis. But my gut feeling is that fungal meningitis would probably be worse.
No.
That's my gut feeling.
The next question is from Dr. Amit. Good evening. If any neonate gets treated for 10 days of antibiotics and then LP was done, what cutoff should be taken mainly for outcome?
Very, very difficult question to answer again. I mean, obviously there are no studies on this. No, nobody would sort of systematically do a study in which you do a reference standard LP in the beginning and then deliberately do another one 10 days later after antibiotics to see what is the change. So at the end of the day, you will be left, with only your clinical judgment. If your findings are clearly abnormal, if they are above the cutoffs despite 10 days, then you are dealing with meningitis. You treat it as meningitis. Now, if they have normalized in the meantime or partially normalized in the meantime, then it becomes a very difficult situation. Then you will have to probably see whether baby was extremely sick, had some seizures, was comatose. Ultrasound shows some CNS findings. You would probably, err on the side of treating it as meningitis because long-term outcomes can be so bad. But then this is not really an easy question to answer. I don't know. I do not know whether PCR would play a role. Theoretically,
Yes.
PCR should be able to pick up DNA of dead bacteria also. But having said that, there's a caveat to it. We had done a study a long time ago published in JAMA Pediatrics, which showed that at least in blood, free floating bacterial DNA gets mopped up by the body's immune system very, very quickly. So it's not that the bacterial DNA just keeps hanging around in the blood after the bacteria have been killed by antibiotics. So within about 12 hours, already the body's systems are trying to mop up free DNA.
Oh,
So I do not know what happens in the CSF, whether the body's immune system is just as good as getting rid of it from the CSF, and whether PCR may have a role in patients who have already received antibiotics. That's an open question.
Sir, the next question is from Dr. Rupam. When do we repeat LP for fungal meningitis, and do we decide antifungal duration based
Yeah,
on
I
repeat
think
LP?
this something similar had been asked before. So for fungal sepsis, there is a recommendation that you should repeat a fungal culture if it is sterile 14 days from then. But for fungal meningitis, there is really no such clear-cut recommendation. So I cannot, really, I don't have any evidence to say that the duration has to be based on a repeat LP. And as I said, it's not easy to keep repeating LPs. Supposing your second LP is positive, then how many times are you going to repeat it now to say that it has become sterile?
Next question is from Dr. Santia. Fungal meningitis, is the duration same, sir, or repeat CSF needed to be document clearance?
Well, again, there are no guidelines regarding this. The duration is probably the same. Again, there are no comparisons of duration, one duration against another. So this is all just, something's written in textbooks or some expert guidance. Repeat CSF if you have proven fungal meningitis. I think given how sometimes difficult it is to get rid of fungi, it would not be a bad idea to repeat a CSF for fungal meningitis before one decides to call off the antibiotic treatment. But again, there is no real guidance regarding this. So I'm sorry, I cannot answer this question with any degree of confidence.
The next question is from Dr. Jyoti. What about prone position LP procedure?
Yeah, so I would not really recommend the prone position. The reason is that the whole idea of being successful in LP is to be able to increase the gap between the interspinous spaces. In a prone position, actually, the reverse is likely to happen. The spinous processes are likely to come closer together rather than see the advantage of the sitting position is that the back becomes a little more rounded and the spinous processes open up, making lumbar puncture easier in decreasing the rates of traumatic LP and getting more CSF. So I would not be in favor of prone position.
So here is a statement from Dr. Jalil Ahmad. Excellent message from legend Dr. Saurabh Datta.
Okay, we can skip that.
The next question is from Dr. Yeshwant. Sir, in case of CSF culture positive meningitis, is it recommended to routinely repeat the CSF culture after 1 week for all organisms, or should it be done only for specific organisms or clinical situations?
Several decades ago, there used to be a recommendation that if it is a proven gram-negative culture-proven meningitis, you should routinely repeat a CSF at the end of the course of antibiotics. But present-day recommendations do not really recommend that. If the patient has clinically improved, if the ultrasound is not showing anything suspicious, then there is no need to routinely repeat the CSF culture. So repeating is to be done only if there has been some clinical deterioration or the course has not really gone as anticipated.
Sir, just interrupting, sir. We had some experience in some of the bugs which have seemed to be reasonably clinically stable child after a couple of weeks, and then again when we just put the probe after 2-3 weeks, then we'll see the ventriculitis in those cases, like serratia especially, which is one bug we had very bad experience. Almost 5-6 cases I can say in the 5 years we had a very bad ventriculitis in the beginning, but now we are more or less doing only for that bug a repeat CSF. Is it okay, or how does
Uh,
PJ experience this?
I really haven't really faced really that many cases of serratia. If you're saying for you may probably be
But
having
this
much
is
more
over a period of
experience than
13
us.
years. Sir. Over a period of
Yeah,
13 years, sir, I'm saying
yeah.
that.
I even over that many years, I don't recollect seeing that many serratia for some reason. Acinetobacter off late, we have started seeing a lot of Acinetobacter meningitis, ventriculitis. Um, Citrobacter is one organism that peculiarly causes more abscesses compared to other gram-negative organisms. So there may be a case for if you have had Citrobacter meningitis for repeating it just to ensure that it has got cleared because and of doing frequent ultrasounds just to make sure that you don't have any residual abscess. But I'm not sure whether for any other organism, routinely there's a recommendation for repeating if the baby has clinically improved and become clinically okay.
We are not repeating for any other organism. Sir.
Yeah.
That's the only organism we are just a little worried because
Yeah,
we
no,
are
no, you may be right, but I don't know.
four
I don't
times
know how
burn.
much
Yeah.
would be the worldwide experience of
Yeah, I
just
don't know.
serratia, meningitis,
Yes,
and
sir.
what happens. Yeah,
Yeah,
but
sure.
difficult to say.
I just wanted to ask one more question. What about fever? Is, fever a marker of meningitis? Should we think about fever as if a term baby
Y-
presents to us with fever?
Yes, you should.
Yeah, yeah, but
Fever is associated with localized infections in neonates. So fever does present if you have, say, a urinary tract infection, meningitis slash ventriculitis, or a deep-seated abscess. So the incidence of fever is higher in such cases than in your routine run-of-the-mill type of sepsis. So you should be a little wary if a sick-looking baby is also having fever, whether he has any one of these localized infections.
yeah, because this fever can be caused by viral infections also. It can at times be environmental also.
True.
So, which baby should we routinely do a lumbar puncture in every fever case if there is no localized infection? That's one more thing which actually was whether we going to miss out some cases of
See, if the baby is sick looking, has say procal and CRP grossly elevated, you're treating as sepsis. You're giving it. You don't really think that
Yes,
you're
you
not
should.
dismissing it as a viral infection. You are treating it as sepsis, and
Janan.
he has fever as a manifestation. Definitely, in that I would do a lama puncture. In fact, we are also very poor at doing urine examinations. Somehow in the West, they do urine examinations far more often than us, than what we do all over India. And I think we miss a lot of UTIs. We get away with it because all the time we are treating with some gram-negative cover.
antibiotics.
See, in the West, they are often treating only for GBS cover, for their especially early onset. And so if there is a gram-negative UTI, that kind of gets unmasked. Our UTIs don't get unmasked because we are anyway giving something with amikacin, and so the UTIs
That,
all get treated side by side without our even realizing
that-
it.
that's
Especially in
very
our VLBW infants, in VLBW UTI incidence is supposed to be higher than in non-VLBW infants.
that's
So
very true,
all
sir. We had a baby who was treated with antibiotics, and again another episode suggestive of UTI. Previously, urine was not done, and he had duplex ureter with reflux.
yeah, I wouldn't be surprised that we are actually missing a lot of UTIs.
Yes, sir. And even in the Western practice, for all late onset sepsis, if it is suspected, lumbar puncture is must before starting antibiotics, unless baby is very sick. But
Yeah.
we don't see such practice in India.
No, I'll tell you what, we are doing this QI project, quality improvement project right now. And even in our unit, there used to be a lot of resistance to doing a lama puncture before the first dose of antibiotics. So all kinds of excuses would be found. Once we actually gave, specific reasons for not doing LP. What is an unstable baby? After all, what is everyone says, okay, a baby is unstable. Let's not do a lumbar puncture.
Objectively.
So once you objectivize it and you say that, it mandatorily has to be done. So that should be the norm. Not doing it before the first dose should be the exception.
Agree.
And then we said that, okay, even if you cannot do it before the first dose, at least try and do it within the first 4 hours before the antibiotic levels rise to such an extent that it is penetrated into the CSF and rendered everything sterile. We found that the first LP rate before first dose of antibiotic rate went shot up like anything. The same, residents and nurses who were totally resistant to it are now doing it. And our culture positivity rate in the course of just, a few months from 3% has gone up to 8%.
Yeah, absolutely. Yeah.
So it is possible to achieve those kind of things with a little bit of effort.
We need to change our culture, sir.
We need to, yeah.
Cultures,
Change our culture. I mean, and there's no pun intended in that, I think.
So the next,
I also remember you saying in your talk that CSF culture has to be put in blood culture. What you
Yeah,
have noticed that?
that's a very good practice actually.
Hmm.
Send the CSF with in a syringe
Back-
and needle, injected into a Bactec
Bactec.
bottle. The culture positivity rates go up.
Hmm.
No, see,
Yeah.
normally we do not do that.
No, we should start doing it.
Sterile
We are
bottle.
now doing it routinely in PGI, sending it in Bactec culture bottles. The
Oh.
culture positivity rates go up.
That's interesting. Yeah.
so the next one
That's
is
the norm now in PGI. Now,
Yeah, all our CSFs are going in Bactec culture bottles.
and then have you found retrospectively? you're
Yes,
following your
we have
culture?
found that the culture rates are now higher ever
Oh.
since we've changed over to this practice.
so the
I
next
think
one is a statement from Dr. Lakshman Kumar. Excellent talk, and a lot of the unanswered questions were answered today. Next question is from Dr. Sharat Chandra. In traumatic LP, any change in protein sugar levels will be there, and how to interpret it?
Yeah, again, like a CSF cell count where the correction factors had been recommended. So there were sort of various correction factors for even protein, that for every 1000 RBCs, you increase the protein by add 1 to the, protein, and likewise for sugar levels. None of these are really based on anything, any hard evidence. And I'm sure, I'm not aware of any studies, but I'm sure if anyone looks at it with any degree of accuracy, it'll turn out that all these estimates are all based on nothing. It's just thin air. So with cell count, it has been found that, correcting doesn't give any advantage. I'm sure the same is true for protein and sugar. Nowadays, we just go by the uncorrected reports. What happens is that if you try to correct, you lose sensitivity and you gain specificity. Now that's a problem with a disease like meningitis, because if you are losing sensitivity and you're gaining specificity, that means you are likely to miss cases if you're losing sensitivity. If you don't correct, it's a reverse problem. That means your sensitivity is high, specificity is low. That means you end up over treating patients who don't have meningitis. So both ways you're in trouble, but you're in greater trouble if you miss a diagnosis of meningitis.
Sir, the next question is from Dr. Jubair Bhatt. How to manage difficult to treat ventriculitis even after 6 weeks of treatment with increasing or not decreasing proteins and negative cultures? Role of intraventricular antibiotics other than colistin. Do you put EVD, Omaya for antibiotics or give it percutaneous?
Yeah, very, very relevant questions. All of us have, once in a while faced these extremely difficult patients that even after 6 weeks, the cell count, instead of decreasing, is actually increasing. Protein is increasing. Now, what do you do? Very tough questions. One is, we just continue. There is nothing sacrosanct about this magic figure of 6 weeks. Some may require 8 weeks. Some we have had cases where we've ended up giving some, 10 weeks of antibiotics also, because it is not normalized. As I said, from the systematic review of the literature, the only evidence that we have is that at least 3 doses of intraventricular antibiotics should be given. That has been shown to be associated with slight reduction in mortality. Apart from colistin, polymyxin B, which is basically a congener of colistin only. I mean, it's a cousin of colistin. Tigecycline and sometimes minocycline has been tried out intraventricularly. So there isn't enough evidence for other antibiotics, like for example, meropenem. There is no evidence that you can safely kind of give it directly into the ventricles or any of the other beta lactams and so on. So experience is limited to only these 2 or 3 antibiotics that I have mentioned. Whether we should put in an Omaya reservoir, if your surgeons are comfortable with it, and if it's a slightly bigger baby, an Omaya reservoir does make things a lot easier because you don't have to each time puncture the ventricle. Sometimes if the ventricular size is not big enough, if the VHR is or ventricular index is not high enough, it is even difficult to even reach the ventricle with a needle. You need that long a needle to get into the ventricle.
Yes.
And remember, each ventricular tap you're doing, you are going through brain tissue. You are yourself damaging whatever neurons are there on the path of the needle every time you're doing a ventricular tap.
Yes.
So with Omaya, at least it's a one-time thing. Okay, you're doing some damage, but at least it's a controlled damage. You're doing it, once. Our neurosurgeons with very premature babies, they have found it a little bit of a problem. Omaya reservoir, the skin starts breaking down, and then that whole area becomes such a mess that it's difficult. So if it's a slightly bigger child, slightly thicker skin, then an Omaya reservoir may be a good idea if you have to give repeated doses.
Lingareddy sir, just to be aware, it's 8 minutes past 10.
Yeah.
So similar questions you can skip, sir.
Yeah.
Because sir also, I didn't, sir has given a lot of time already to us.
It's already,
So-
more than half an hour of
Yeah. Next question is from Dr. Jyoti. Kindly share reference CSF values for term and preterm. Are there any reference values for gestational age wise?
Sir already shared. No?
Yeah, so this is there in one of the slides.
Yes, sir. Yes, sir.
So next question from Dr. Amit. If any neonate has taken antibiotics outside for suspected sepsis for 7 to 10 days, CSF findings come positive, then should we count that 7 to 10
Depends.
days and give a total of 21 days, or starting from the day when we get the CSF positive for the meningitis to have total of 21 days?
Depends.
See,
WBC as total should be taken, or polymorphs or lymphocytes should be taken separately.
yeah. So, okay, the first question first. So, so this is not peculiar to meningitis. The same question could be asked of sepsis also. So, if you've already been treated. Now, if you have a culture which is positive and that shows the sensitivity of the organisms, the previous 7 to 10 days was also a sensitive organism, then you will include it in your total of 21 days. If it was resistant, then you will not include it. Secondly, if the culture is negative, but for whatever reasons best known to you, you have continued with those same antibiotics which were given for the first 7 days, and the child has improved, suggesting that it was sensitive, a surrogate marker of it being sensitive, then you include those 7 to 10 days in your total duration. But
So
if you have changed the antibiotics or the previous were resistant, then you don't include. So it's not something specific for meningitis. For any infection, I think the general rule would be used.
Next question from Dr. Azlal Hassan. We routinely don't perform ventricular taps. Is neuroimaging a prerequisite for ventricular tap, or should we rely on clinical features? How often should we perform it considering its risks?
Yeah. So obviously, because it's a much more invasive procedure than a lumbar puncture, it is not something that should be routinely done.
Done.
And I think it's a good idea to do neuroimaging definitely before a ventricular tap. After all, you want to know whether the ventricular size is big enough for a tap to even be successful. You may not even be able to reach the ventricle if the ventricle is not large enough. So yes, neuroimaging should be done before a ventricular tap, at least an ultrasound, and don't rely only on clinical features. Quite often, ventriculitis will announce itself by poor clinical response to treatment. That's the usual way in which you start suspecting that, okay, this is not your typical garden variety of meningitis. This could be complicated by ventriculitis. Yeah,
So
okay.
next one is from Dr. Lakshman Kumar. Any change in the spectrum of bugs causing neonatal meningitis from gram negative organisms to gram positive organisms? Please comment.
I'm not sure I've understood this question. Are we trying
Any
to
change
say
in the
that
spectrum of
over
bugs?
time, are we seeing a change
Yeah.
in the organisms?
Yes, sir. That's what it means, I assume.
Okay. Yeah, I think we have, because Acinetobacter, which was, I think unheard of practically maybe 15, 20 years ago, is
Now,
now a pretty common bug, at least in North India. I think it's pretty, I don't know how
Yes.
it is in Telangana,
Yes,
even
sir.
we
but
Here
had
it is, and
in
we see it quite often in cases of meningitis. And that's
and,
definitely one change that has
in
happened
my
in,
unit, Acinetobacter is the commonest.
and
yeah.
sadly, there are MDR, sir. They are
They
carbapenem.
are all MDR, and you end up giving, colistin, and colistin very poor CNS penetration.
Yes, sir.
So sometimes you're really stuck, and then you have to go to things like minocycline, which one should not ideally do, because these are all reserved drugs
Digicycline,
and the WHO
minocycline.
reserved drugs, and we are all in a mess. We
Yes,
should
sir.
be spending more effort in trying to prevent infection.
Absolutely.
Sir. Next question from Tarun Reddy. Can we plan the duration of antibiotics based on the organisms in proven meningitis cases?
Yeah, as I said, I think this has been covered before. That
Yes, sir.
Western literature says GBS meningitis, you can probably get away with 14 days. Anything else, you have to give 21 days.
Next question from Dr. C. Nirmala. If not improving after starting antibiotics, is there a guideline to repeat LP and CSF analysis? If so, when? I think
Yes, yes. If the baby is, as I said, I've already said that several times. If the baby is not improving, then you should repeat an LP, and you should do a cranial ultrasound, because it could be that the patient is not responding, or a complication of meningitis has developed. And complications include, the three major complications. Ventriculitis we keep talking about, but there could also be an abscess as a complication, or there could be a subdural empyema as a complication. Much less common in neonates, but it could happen.
Next question, someone asked from their Redmi phone. GRBS before doing LP, is it mandatory?
Sorry, I couldn't. GRBS is.
So
Mandatory
doing
before doing LP.
blood sugar doing before lumbar puncture, sir. So that this level of
Yeah.
part of
I
the
mean, most guidelines would say,
yes.
the CSF glucose to blood glucose ratio.
Glucose.
The trouble is, I mean, I think only saints do that actually, because in real practice, very difficult to find people doing the blood glucose before the lumbar puncture. And world over, this is a problem that people forget to do the blood glucose before the lava. And there's no point doing it after the lava puncture, because blood glucose rises as soon as the needle prick is there, it rises. So ideally, yes, you should do it before the lava puncture, but I think very few people end up doing it in real practice, and a lot of the guidelines have now shifted towards simply giving an absolute cutoff for hypoglycemia rather than the ratio. But if you are really interested in the ratio, it is something like 0.6. So if the CSF glucose is less than 60% of the blood glucose, you would consider it to be. So certainly, if a patient has hypoglycemia or hyperglycemia, one of these two, you should do a blood glucose before doing the CSF glucose. If that glucose is has generally been in the normal range, then you just take an absolute cutoff of the CSF glucose. I think that would be a reasonable approach.
Sir, actually, usually we do GRBS rather than blood sugar before LP, and after LP, we are sending blood sugar, CSF sugar. So we need to adjust that 15% or not needed. 15% difference between blood sugar and GRBS.
You means to say point of care and the lab glucose, sir.
Yeah, I mean, ideally it should be the lab glucose.
Yeah.
Knowing all the fallacies of point of care.
Usually we do, many
Yeah.
people will do GRBS only.
Yeah.
Point
Sir,
of
next question from Archana Kashyap. Sir, is a recording available? It's there, sir. We'll share. Next is Dr. Jyoti. Sir, if MRSA positive, blood culture positive, and CSF proteins raised, but CSF culture sterile, then is it okay to give 14 days antibiotics or need 21 days?
answered.
So if MRSA positive blood culture,
CSF
and the
culture is
CSF
negative.
culture is sterile, CSF protein raise, is it okay to 14 days or need 21 days? Okay. Now, firstly, as a general statement, gram-negative organisms are far more prone to cause meningitis than gram-positives.
Okay, yes.
If it is staph epidermidis, almost never does it cause meningitis unless there is a foreign body in place. That means there is already a VP shunt or an Ommaya reservoir or something. Then only you get to see staph or cons meningitis. Otherwise, you don't normally see. Staph aureus, you may still see meningitis.
Yes.
So here, if my cytochemistry is suggestive of meningitis and my MRSA is blood culture positive, I think I would give 21 days of antibiotics and not 14. The 14 days has been recommended only for GBS amongst the gram positives, not for all the entire gamut of gram positive organisms. And particularly Staph aureus, I'd be worried because it is one of those organisms that is very capable of causing micro abscesses wherever it goes. It necrotizes tissue and tends to stick on in tissues. In fact, I would even be worried if it is really Staph aureus meningitis that it should not cause an abscess, an intracranial abscess, requiring even longer than 21 days. But definitely, I would give at least 21 days of antibiotics if it is Staph aureus meningitis, not
We
14.
had one Staph aureus case 10 years ago, sir.
Mm.
Multiple small abscesses. This was a
Yeah.
delayed case of late
Yeah.
onset sepsis. Yeah.
Staph aureus has this property. It's not like other bugs. It's a dangerous bug.
Yes.
It is very capable of causing micro abscesses, which require longer durations of antibiotics.
Lingared, sir.
Next is Dr. Pooja Sharma is thanking you for your good talk. And next question from Dr. Amit. WCS total should be taken or polymorphs or leukocytes should be taken? I think you have answered these questions.
Yeah.
Next is from Nibe. Sir, should intraventricular drug administration be done only through EVD?
Is
No,
also
there is no such rule that it has to be done only through EVD. If the ventricle size is big enough, you could, and if you're not planning to give too many doses, you could just give individual doses directly intraventricular. But if you're stuck in a situation where you have to give very prolonged antibiotics, if the ventriculitis is not responding, you think you need to give intraventricular for a longer duration, then yes, you should consider an EVD.
Next is from Dr. Jalil Ahmad. Any role of early DEXA in reducing the obstructive progression like what we sometimes use?
No, there is no such role of dexamethasone in neonatal meningitis.
Next is from Dr. Srishalam Kotturu, our past president of NNF Telangana. How much volume of CSF if you are sending it in the culture bottles?
Yeah, so you should try and send at least 500 microliters. Obviously, the more you send, the better it is. But at least 500 microliters. If it's a bigger baby and you can send closer to 1 ml, then that's even better. But at least 500 microliters.
Next question is from Dr. Rupam. In traumatic LP, if CSF culture shows organism, is there any possibility that there is actually none, but since there has been a trauma, it's only showing the same growth what was found in the blood culture?
Yeah, that's a good question. Even I have thought of it many times, whether this is simply the blood seeping into the CSF and that's what you're picking up. But also think of it this way. If it has seeped in
then
because of your traumatic LP, you have caused meningitis. So you might as well treat it. You've caused it because it has seeped in because of the blood. So, either way, you would
rather
end up treating it. On the other hand, I don't know. I mean, traumatic LP, hopefully the amount of blood going in is trivial. It's not that, entire some few mLs of blood have gone in because of a traumatic LP. If that is the amount that has gone in, the bacterial density may not be high enough to be actually get picked up on culture. If it is just a few cells that have gone in, and if you have picked it up, perhaps it is actually a genuine meningitis and it's not simply being contaminated by the little bit of blood that has gone into the traumatic LP. So either way, I think I would treat it.
So at this point, I just want to ask, what are your views about why does a traumatic LP occur? Why
simply because
you have done a QI on this, so what were your thoughts on that?
Yeah, so one is that we don't give enough
sedation.
analgesia. So just a gauze piece in sucrose put into the baby's mouth plays a huge role in quietening the baby and allowing it to be done. Secondly, residents always seem to be in a hurry, right? And LP is not something to be done in a hurry. It should be done quietly. The third is positioning of the baby. The baby should be brought as close as possible to the edge of the cot or the bed where you're doing. The nurse should hold. The back should be vertical of the baby. The back should not be turned towards one side. And something very important, the person who's doing the lumbar puncture should bend so that their eye level is almost at the level of the baby's spine. Because otherwise, the parallax makes you think that your needle is horizontal, but actually it's not horizontal. It is at an angle when it's going into the spine of the baby. So if you just take care of these small little things, the traumatic LP rate comes down.
Depth also, you were also saying that in your
Yeah,
case
the needle
study,
size.
the needle size according to the weight. What is it?
Yeah. So I can actually share that, we had made a little table, which we, by gleaning the literature and whatever is the recommendation in textbooks, that you don't use the same size needle, for all weight babies. So for extreme premature babies, we are actually using narrower needles to do the lava puncture. The CSF flows a little more slowly, so you have to be patient, but the traumatic LP rate decreases. See, it's very easy to get into that epidural plexus of veins, which is there. If you're just away from the target, the bullseye by even 10, 15 degrees, if your angle of your needle is missing that.
Yeah.
Sir, always doing with LP needle only, or like
No. We are using standard hypodermic needles to do it. I mean, the risk of, an epidermal cyst, which is a theoretical thing, is so low that, we just use normal hypodermic needles
Sir.
rather than LP needle.
Next question is from Dr. Srinivas Kalyani. Sir, in your vast experience, what is the earliest sign a meningitic neonate is heading for hydrocephalus and the role of acetazolamide thereon?
Well, the earliest sign is usually radiological because, as you know, the sutures separate in neonates. So by the time you actually get, clinical signs of hydrocephalus, it's probably too late. Occipitofrontal circumference measurement should be done in these patients, but you know how much is the interobserver, differences in that. And the problem with OFC is that, see, the brain matter can get compressed. So you may have hydrocephalus developing. If the brain matter is getting compressed by that, your OFC really may not change much. So if you're relying only on OFC, not doing cranial ultrasound, sometimes you may completely miss a hydrocephalus. In fact, I would be worried if hydrocephalus is developing radiologically, but the OFC is not increasing. Because that means the brain is being hit from both sides. So you have to do an ultrasound to be able to pick up hydrocephalus early. And acetazolamide, frankly, whatever little data is there, has not been shown to alter the course of hydrocephalus in neonates.
Sir, next question is from Dr. Rachana Kashyap. Should a shot of DEXA be given?
So I think Dr. Tejo has already
we have answered
replied to that.
Sir.
Thank you, Tejo.
Next question is from Sriram, Dr. Sriram. Sir, focus USG, is it useful to determine the depth of needle insertion? The same thing you answered.
I don't know the answer to this question, but as I said before, there are a few small studies, not very conclusive, but which seem to suggest that you could try and use an ultrasound. I think Dr. Ravi Shankar said that they themselves had done a study
we have
on
done
this.
that. We actually do an ultrasound to just see where is the conus medullaris.
Yeah.
Then we can identify, we can, avoid the spinal cord. And we can tell exactly where the spinal cord is ending and where the space is. It's very beautiful. If you do an ultrasound with a linear probe, you can see it very nicely. But that doesn't
translate into
a successful
significantly Yeah.
So that is again the same thing. So
Right,
and
right.
you were saying there's so many other things which we
Yeah.
need to take care of it. Yeah.
Lingareddy sir, Nirmala madam and Srishalam sir
Yeah.
both are there.
Yeah.
And then we can conclude. I think it's already 2 hours for sir.
Yeah.
Yeah.
I think we should, wind it up now.
That just
May,
shows
may,
that there are still too many unanswered questions in this field.
no, sir. So, a few
The-
comments from Dr. Nirmala ma'am, NNF Telangana chapter president. Ma'am, are you here?
Unnar, madam, unnar.
So good evening. It was an excellent session and with so many questions coming up and you have been patiently answering and a lot of doubts have been expelled. I mean, have been clarified regarding the repeat LP or the how to diagnose ventriculitis or when to do, how to correlate the findings of CSF with uh, the patient improvement and all. Thank you very much, sir, for
Thank you. Thank you.
being here with us. And you have always been a great speaker. I heard you about 15, 20 years back, I think, and in one of the national conferences where you spoke about meningitis. And thank you so much
Thank
for
you, ma'am.
coming.
Thank you.
Dr. Vijayanand?
Okay, so you want some. What I want to say with the broader perspective, what I read it from the one of the educationalists, the real learning is a learning which not only answer your questions but generate new questions. I think today's session for Saurabh sir is a true example of that statement. And sir so openly and discussed all the questions and also openly said that we need to be keep open for the unanswered questions to be answered and also to take the new questions as emerge. And is a true example of a pluralist thinker. He is not a no person. And it also says how evolve we spiritually with the broader perspective, keeping open things as they are rather than saying this and that. Thank you very much, sir. I salute to you and your time and sharing your experience. And we really appreciate today's session. And it is half past 10 o'clock. Even there are 50 people listening to you. And as a great discussion, and from bottom of my heart and on behalf of Telangana State NNF, we really thank you, sir. I stop it.
Thank you for the opportunity. I don't think I deserve all those
Thank
No,
you.
words
sir, you do.
that
You
you
do.
said.
Thank you, Dr. Vijayanand.
But thank you nevertheless for your very kind words.
Thank you, Dr. Vijayanand, Secretary of NNF Telangana chapter. And while the talk was going on, always it was 100 members. We have only 100, what you call,
Yes.
maximum. Any words from you, Dr. Srishal?
Thank you, sir. It was an awesome presentation. And sepsis and neonatal meningitis is a never-ending saga, and I think
Yes.
very interesting subject. And I think everybody loves to it. And as Lingareddy sir was saying, that 100%, 100 viewers were glued upon right from the start of your talk until the end before you were answering questions, and they stay till the end of your talk, sir. That itself tells your the interest in neonatology, and you are an excellent speaker, and you never let down their expectation. And today we saw it once again. And NF Telangana is very happy to have you here, sir. We feel it's a great honor and a success among all the webinar series that we have been conducting. On behalf of NNF Telangana, I would wholeheartedly thank you on this festive day with multiple states celebrating their new year. And happy Baisakhi and happy
Thank you. Same
Coconut.
to you.
Thank you, Dr.
Thank you.
Srishalam, the
Thank
past
you for
president of NNF Telangana. Now may I ask Dr. Tejo Pratap, Treasurer of NNF Telangana, to give word of thanks.
Okay, thank you. Thank you, Lingareddy sir. I think all of the members already have given the sir words about sir's lecture and everything. Only thing I can say in one sentence, which we have been seeing sir since last 15, 20 years, and then he has that magic of making the complex science and statistics into a beautiful way of delivering through a PowerPoint. We all learned from you about that PowerPoint. So maybe I don't think that we'll match it, but we have done reasonably some of the clues what we have to do in our presentation and other things. I would like to thank Ravi Shankar sir for chairing the session, and we thank our convener Dr. Lingareddy sir for coordinating it, and we'll also have acknowledging the presence of our President Dr. Nirmala Madam and Secretary Dr. Vijayanand sir and Sri Selam sir, and I can see a lot of seniors also who are there. Alumini Madam was there, and Balram sir was there. Senior neonatologist like Sri Ram and everyone is listening since the beginning till the end. That shows the interest on the sepsis and meningitis is one thing, and then definitely we are all looking for the more answers from you, sir. We would like to be part of any of this saga in solving the paradigm of sepsis and meningitis at any point. Thank you very much, sir.
Thank you, sir.
Thank you.
Thank you, one and all. We'll meet in the next month.
Thank you very much.
Thank you.
very
Thank
much.
you very much,
Thank you.
sir.
Have a good day. Have a good festive season.
Thank you.
Thank you. Thank you.